there's one circular band of muscle is there at the bottom of our esophagus, that is called as the food pipe, which opens up and allows the food to go down and closes back again. It works as a sphincter. Sometimes we call it as a valve. So whenever this valve becomes abnormally lax or abnormally weakens, no, in that case, not only the food goes down, in some events it may reflux back up. Then it is called as the reflux. And this constant backwash of acid, always because the food pipe is not made to handle the acid or the food contents. So it starts irritating the lining of the food pipe. Then it starts getting irritated, or we call it as inflamed. So I'll show you a brief video on this. Now, how the normal food goes down this. This is the diaphragm, which is not a respiratory muscle, which divides the two components, the chest and abdomen. This is the food pipe, what you're seeing down the straight line. This is the esophagus, and through an opening in the diaphragm, it enters into the abdomen. Now, this is the stomach. This thickened, a constricted part, what you're seeing is a lower esophageal sphincter, or we call it as a lower esophageal wall. Now, you see the food bolus is coming from up. It is entering into the stomach. The floating thing is here in the acid. Once goes down, the wall gets closed. But whenever it's an abnormally open, we can see the contents of the stomach, like whatever the fluid is there. It's an acid that is going up and coming down, going up and going down. Now, whenever the acid starts entering into the food pipe, you start seeing irritation around that. So whenever it starts irritating for a longer duration, you will start finding a development of wounds like this, which is called as the, or we call it as an gastritis, or the whenever it happens in the food pipe, we call it as the esophagitis. Going further, now what happens when this type of reflux start happening? Now we have to understand specifically this topic is only on the gastroesophageal reflux disease. It's just a reflux only the whenever the food comes up or the acid comes up. This is not about this. There are alternate terms are used like a bloating or indigestion. Some people call it as dyspepsia. It's not that. It's only for the reflux disease. Now, whenever that acid starts coming up, now when you start getting wounds, so you start a feeling of say pain around the lower bottom of your chest, medically or sometimes socially, or this is called as the heartburn. Usually after eating, because once you start eating, your stomach bloats up and the contents tends to push up. It becomes more worse in the night because the nocturnal acid surge will also be there. Sometimes it may present as a chest pain. So many of the times the ERD or this will be getting confused with the cardiac attacks. So that's what one of the symptom of GERD is also a chest pain. Now sometimes you may experience the food coming up to your throat, or the sour liquid, or the partially digested food can also become. And sometimes some people will get water brash. Water brash is whenever the reflux contents get mixed with your saliva. So a lot of fluid type of thing, which is a bit citric or sour, you start getting into your mouth. That's called as the water brash. These are the few symptoms, common symptoms. Apart from that, if the reflux is there for the longer duration, you will start finding difficult in swallowing because you saw the wound is developed in your food pipe. That may also start hurting you to swallow. Sometimes a sensation of lung can also be heard. Because of this development of irritation and ulcers in your food pipe, you'll start developing a bad breath also. Now, there are some non-typical, or we say the atypical symptoms of reflux also. Sometimes if you have a nocturnal reflux, like if you have the reflux coming up in the night time, especially during the sleep, some patients, they tend to develop a chronic cough on this because whenever the acid comes up, it starts to spill over into your windpipe, also causing chronic cough. Laryngitis is wherever your voice starts getting affected, getting a hoarse voice. Some people, because of this chronic cough and all, they have been like having an say diagnosed, maybe not wrongfully, I will say, maybe not correctly diagnosed. They will be like treated as asthmatic patients, and even it also disrupt your sleep as well because of the chronic reflux coming back. Now, apart from the laxity of the wall, there is also factors which aggravates the acid produced into the stomach. Now we have to see what exactly aggravates the things. We see the acid reflux or the aggravation in the acid production is more those who smoke, those who have a large meals, or especially eating very late in the night, and there are some trigger foods which stimulates the formation of the acid into such as the fatty or the fried foods, and certain drinks such as tea or coffee, and caffeine products, and certain medication, especially the painkillers, the diclofenac, or the we call it as the NSAIDs, and as well as the aspirins. And whenever you are stressed, you might have been noticed yourself that whenever you are too stressed, and then time those reflux episodes seems to be more pronounced during those these are this thing. And those, and we have to see who are or in whom the most commonly the reflux is seen. It is not like only these people are prone to that. It can happen in anybody whenever you have an aggravating factors or whenever you are at risk. Especially we see more in the obese people, because of the lot of fat accumulation inside your tummy. It tends to push up your food pipe into the chest, aggravating the acid reflux. The pregnancy also one of the common reasons, because the developing baby down into the uterus can also keep pushing your food pipe and stomach. And also it's one of the very stressful period which adds to the acid formation. And there are few people who develop one entity called as hiatus hernia. Now, what is hiatus? Hiatus is an opening from where the food pipe is coming down into the abdomen. So that opening is called as hiatus. Normally, it is just of a size to allow the food pipe to go down. But whenever it becomes dilated, so the food pipe starts getting into your chest, then it is called as the hiatus hernia. So the protrusion of a part of your upper stomach into the chest is called as the hiatus hernia. So these are the risk factors we see very commonly in the reflux disease patients. Now, since my topic was absolutely on the surgery, I just wanted to give a brief on what exactly is the GERD and also how it is diagnosed, so that it will be helpful for me or my the viewers to understand what exactly and how my surgical treatment will help you in getting treated of this diagnosis. Now, the diagnosis of GERD is mainly clinically. Whenever you give a symptom history, that's fair enough to diagnosis of a GERD. And the moment we clinically see you and say that you are having a reflux disease, we start you upway straight way to the treatment itself. But there are instances where we need to confirm, because whenever you started on treatment, if you're not responding, we need to confirm back by doing some investigations. And one of the very common, or I'll say one of the main modality of diagnosing GERD is an endoscopy. Now, endoscopy, I feel like it's a very commonly known investigative procedure. Uh, done day in and day out. I'll just show you a brief. It's endoscopy is nothing but a long tube with a camera at the tip, so that we can see what is happening inside of your food pipe and the stomach. This is the endoscopy. I'll show you a brief video. How is it done? Now, on your right hand side, you can see a picture of
through a nasal cannula. Uncomplicated upper endoscopies take between 10 and 20 minutes. Your doctor will gently insert the end of the mouth and then slowly and carefully move it down your esophagus until it reaches your stomach. And finally, your duodenum. You should feel no pain as this is happening. Your doctor may periodically introduce a small amount of air to flatten the mucosal lining and improve visibility. If your doctor would like to collect a sample of tissue, he or she will obtain one or more biopsies through the endoscope for later examination. A biopsy will help distinguish between benign and cancerous.
So this is how the endoscopy is done. A tube with the camera at the tip, you can see it is going across your mouth, going down into your food pipe. Once it reaches into the stomach, this is the stomach. So all the information is recorded, seen on the monitor. We see what exactly has happened here, whether the wall got loose, or if there is a lot of ulcers, or if there are any effects are seen, or if there is any blockages have developed. So once inside, this is the inside view of the stomach, and if any abnormality is seen inside the stomach, and we need to take up a small tissue bits to make sure what exactly is happening. Is it just a simple ulcers, or if there any progression for some further progression into a disease is happening, that we have to take. This is the biopsy is being taken as small forceps, which takes a smaller bits, and it is absolutely safe to do this. Absolutely safe. Nothing to be worried about. Now, once endoscopy is done, patient is started on the medications. I'll come about the treatment, how exactly is done. And I just want to highlight upon some other tests which can be done also. Endoscopy is the main source of diagnosing it, but there are other tests when a patient, in spite of being treating with medications, changes in his all the dietary patterns, they tend to have the reflux continuing. In such patients, we do some special test called as the 24 hours, the esophageal pH monitoring. Now, this is one of the very gold standard tests what is used apart from the endoscopy. Here, we just not only see the reflux episodes, means like if you are suffering from say particular time of a day, and when you get a reflux, like is it during the sleep you get the reflux, or during the what you say just immediately after eating the food you get the reflux. This all recorded into this type of a study. This is like almost you have to stay 24 hours in a hospital. A small probe is inserted through your nose and it goes down to your food pipe and stays into the stomach. Then you will be given a handheld device where you have to just press a button whenever you get a reflex episodes. Now, this is a very objective way of documenting the reflux. See, the reflux can be because of just food, or it can be just the bile which is coming from down the small intestine, or it can be just an air also. So, to exactly quantify what is refluxing up, this test is that this 24 hours PS study is done, and this gives us a value. Or one cutoff value will be there. Based on that, we decide how the treatment is to be done. Now, this is not done at upfront. It is done only after a certain point in your treatment, not just exactly. And apart from the esophageal pH study, and there's another study called as the esophageal manometry. Manometry is nothing but to see how your food pipe is functioning. Now, we have seen that food pipe, the lower end is become abnormally loose or lax. That is causing the reflux, or is it the entire food pipe is that is being under trouble? So, with this manometry, we see how the food pipe is functioning, how much the contractions are the food pipe is giving you, how much it is allowing the food to go down, or is the food sphincter is opening or not, or it is abnormally open. So these two tests are usually done not at the upfront. Usually during the course of treatment, your doctor decides upon. If you are not responding well for the regular treatment, then this study will be done. Now, what if like no, I have been given treatment, if it is not responding, or if at all the GERD is not treated, now what complications we can expect from this? Now, I said, since the acid is coming up through your food pipe to into your food pipe, the food pipe is getting irritated, so it starts getting inflamed. Nothing but it's called as inflamed. Then we start developing ulcers in the food pipe. It is called as esophagitis. Esophagus is the food pipe, and the irritation of it is it's called as esophagitis. And it can, because the ulcers are formed, it heals also. See, whenever it heals, it may heal with forming some fibrosis. That is, see, whenever you can also might have noticed in a day-to-day this thing, that whenever you get an injury over the skin, so it forms with the scab. So that is kind of a fibrosis. So if the fibrosis type of a thing happens in the food pipe and the food pipe gets narrowed, then it is called as a stricture. And sometimes, because of the long duration of exposure of the acid to the food pipe, because the food pipe is not made to handle the acid, so the food pipe starts converting into some other forms of covering, and that is called as the Barrett's esophagus, and it's one of the precancerous lesions that happens. So we'll come here. I will just show you a videographic representation of what exactly can happen. Now, this is another same video, how the reflux can happen. This is the stomach, what you are seeing. This is the diaphragm, and this is the food pipe, what we are seeing. Now, the acids in the stomach, it is there, it is secreted. It's a natural way to have a stomach acids in the stomach. The hiatal hernia is formed. The food pipe is getting into your chest. Now, the acid starts refluxing. So, whenever the acid starts coming up frequently, commonly, it starts forming wounds in your the food pipe starts getting ulcers like this, which may cause heartburn. Sometimes it may bleed. Whenever they heal, they form a scar tissue, and that narrows your food pipe, forming a stricture. These will not happen in a day to day. They will happen only whenever the reflux is there for very chronic, or it's called as the very long duration of reflux. Now, if the reflux keep on continue, I said food pipe cannot handle the acid. It starts forming an abnormal covering over the previously formed esophagus, the food pipe covering. this abnormal lining is given a name Barrett's. The one it is named after a person who first found it. It's called as the Barrett's lining or the Barrett's esophagus, and it is one of the cancer lesion. So in the right hand side, you can see this is the esophagitis. You can see there's so many red formation of ulcers around there. The stricture is whenever the narrowing happens, and this is the Barrett's esophagus. Now, what's the problem with the Barrett's? Barrett's is one of the I'll say a pre-cancerous stage. It has not gone into cancer, but it has got a high tendency to develop into a cancer. As you can note in my lower slide here about the Barrett's, so the Barrett's has a tendency. So if some person develops a Barrett's esophagus during his disease course, he has approximately 0.5 chance of developing an esophageal or the food pipe cancer. And this risk is when you compare it to the person who doesn't have it's a 30 to 50%, the 50-fold increase in the risk of esophageal cancer. So this should not happen. Make sure that we get to diagnosis at an early stage so that we can prevent the complications happening further. Now this is how it is happened. So moving ahead, now I'll come a brief on treatment. So in the reflux disease, the treatment is never will say never just with the doctor. It's I expect my patients to be uh, more cooperative in the treatment of reflux disease because the two most important component of reflux is diet and changes in the lifestyles. These two I can only advise, but the following it maybe with sincerity, it all depends upon my patient. If you see my this chart, during the entire treatment modality, the diet starts from here till to the end of the arrow. Means the surgery is only the fourth component. So this is the topic of today. But to come to you, I have to make sure that I reach. I should tell you what exactly that GERD is treated. So surgery is only the last option. Please consider it, and it's a very one of the good option also. But before that, there are the treatment modalities with the diet, lifestyle, as well as medicines. I'll go very brief on this because since the topic itself is on the surgery. So what are the dietary changes you have to see? The dietary changes advised are you should have to have a low fat diet, high protein. You have to stop smoking because you see one of the risk factors for aggravated acid production is smoking. You have to reduce your alcohol intake. Caffeine should be reduced. Soft drinks such as colas and all has to be reduced, and spicy food is. These are the very blanket terminology I'm telling. We can have a separate session on these separately. I will feel it is not just simple like to tell somebody to eat a low fat diet. I have to enumerate what are the low fat diets and all. But this is out of scope of this presentation. The lifestyle changes are also advised, such as daily exercises. You have to lose the weight. See, obesity was one of the reasons. So we have to lose the weight, avoid tight clothes. You have to chew well, eat well. So all these lifestyle changes will be advised. Now, whenever the dietary and lifestyle changes are advised, along with that, some patients need medication also. The medications are mainly, when you saw during my initial presentation, the reason for getting reflux is the acid coming up to your food pipe. Now, how to treat it? You reduce the acid, okay, either by changes in your diet and lifestyle, and also by giving some medications, which is nothing but the antacids also. And also you make sure the stomach get emptied of the acid as early as possible so that the reflux doesn't happen. So these are the most common drugs that are used. That is the PPI, that is the prokinetic drugs. H2 blockers are nothing but they're all the same acid reducing medications. And another option is available is a laparoscopic or the anti-reflux. Now we have the reflux, so we have to make it anti. So it is called as the anti-reflux. So the treated by laparoscopic approach, that is called as the laparoscopic anti-reflux. Now we are coming to the topic of the day. Even though I had only 30 minutes of talk, I have taken 20 minutes on this, but we'll try to get it because I said surgery is on the last option. So we have to keep it at the last. Now, how surgery is going to be done? So where are the cases where surgery is indicated? See, whenever we diagnose a patient to have a reflux disease, and we put him on changes in the dietary lifestyles, and sometimes we put them on medications. And in spite of that, patients are not responding up there, or if they are not able to maintain their say symptoms under control. So those are the ones who will be suggested surgery. And also another one problem with medication is that The medications need to be taken for quite a long time. Sometimes it may be lifelong because we have to reduce the acid for the life. Then only the symptoms are getting under control. Now there are persons who cannot able to manage this with daily intake of medicine, so they may opt for the surgeries because they may not be able to, or they may not be willing to take a lifelong medications for that. And sometimes there may be a social consideration that expense of medications for the lifelong, they may also be more than what definitely a surgery can cost. And sometimes any medications, if you are taken for a very longer time, it starts giving its own complications. We see, though it's very rare to get a side effects of these medications, but still they are documented, especially the kidney problems or sometimes a tumors developing in your stomach also. And another where condition where the surgery is indicated is a large hiatus. When your entire stomach has gone into the chest, then only the surgery is going to relief. I mean, to give you relief, not exactly the medications. So other very common indication for surgery is that if you had a reflux for a very long time and you started complications, I just mentioned previously in my previous slides that you had already had complications such as, you started developing barrettes, or if your food pipe started developing narrowing, or if you're the food pipe developing a high grade ulcers. So those are the cases where the surgery is advised upfront, and some special cases like laryngitis, asthma, and disturbed sleep. Now, how this laparoscopic surgery is done? This laparoscopic surgery is done under a general anesthesia. General anesthesia is the one where you will be given injection through your one of the peripheral veins. You'll be made to sleep, and the anesthesia is given through a tube from your mouth to the lungs. So you will be completely unaware of the surgery is being happening. And laparoscopic surgery is completely, I will say a very minimal invasive, or is it done through very small cuts, around 3 to 5 small cuts of approximate 5 millimeters. 5 millimeters is such a small, and through which the doctor or the surgeon puts his instruments inside to operate, which using a camera and handheld instruments. I'll show you a brief video how is it done also, and what exactly surgery is involved is nothing but whatever that lax valve has been become lax, we tighten it, or we do it, or we reinforce it by using a small part of your own stomach. Okay, this is like a creating a one-way wall. Now this is a small animated video. I will show you how the laparoscopy. See, as on your screen you can see there are a small holes are made like this. These are the laparoscopic holes. It will be around 5 millimeters. Though it is animatedly shown as round, it is always a small horizontal cuts will be there. After this cuts are made, we put working ports. These are the small working ports through which our instruments and the camera goes inside. Just okay. Yeah, our camera goes inside through your belly button, and once inside, we see this is the same video I showed you last year where the abnormality was located. Sorry. Yeah, go ahead. So this is the area where the abnormality was, this the sphincter was lax, and the hiatus are near where the laxity of your opening in a diaphragm is in. So we laxity is close to the sutures. It will be 2 to 3 sutures depending upon the case wise, and the artificial wall is created using a part of your stomach. That is called as the fundus. That's a part that is wrapped around your stomach, and 2 to 3 stitches are taken so that this reinforces your esophageal sphincter. Now it is like an artificial wall that is created using your own stomach. So we are not going to use any extra foreign bodies here around because it is safe to use our own native structures. So this sphincter is created. So it's like a forming again, like a natural, normal kind of a barrier for your acid regurgitation for happening. Now this is that was an animated video. This is the actual video of or the inside view of how the laparoscopic surgery is done. Now these are our hand instruments, what you are seeing here, and that's the stomach is being rolled. This is center one is your food pipe. So the stomach is used. Now whatever that opening was there in your diaphragm is being closed with the sutures. See how meticulously each structure we can see through the laparoscopy. So laparoscopy has got almost a 10 to 15 times of magnification. So we see each critical structures with as close as possible. Now these are the sutures that is used to close the defect over there. It may require 2 to 3 sutures depending upon the case. This thing now that is narrowed. So the opening, a lax opening is there, that is narrowed down. Now artificial wall is started being created. Now only the stomach, see like this, the stomach is rolled upon your food pipe so that it prevents the backflow of acid from your stomach back into the food pipe. That's it. So I just wanted to show one more other complication, a large hiatus hernia I was telling. This is where you can see the entire stomach. You can see the stomach which has to be back normal into the stomach. This has gone up. Now here the medicines will not work. This has to be created. I mean, this has to be corrected surgically. Only see how the entire stomach has gone up. It is being pulled back into the normal position. Entire stomach is into the chest. Now this is the normal location where it is placed. After this, we create the closure of the valve and an artificial valve. So this is about how the laparoscopy is done, right? So what expected after surgery? Now this surgery will approximately take around 45 to 60 minutes, not more than that. If you do it in a good center, I mean, actual time of surgery should be anywhere between 45 to 60 minutes. You will be started on the liquid the same day. Once you are out of anesthesia, say approximately 4 hours, and you will started on the soft diets within 24 hours. Hospital stays almost 24 hours, means you have done surgery today morning, the next day morning you will be sent home. Since it is done entirely by the, I'll say, no scar surgery, so the pain is going to be very minimal. That is present only for the first day or maybe first 2 3 days, then which can be definitely managed with the painkillers. You will be advised, or you will be able to do your all regular activities like such as showering, driving, walking upstairs, downstairs, whatever walking basic household works you can all do. And most of these patients, because we have already created an artificial wall, you don't require any reflux medicines immediately after the surgery. See, you can see this is the actual photo of a patient which has undergone, see the small, minute, tiny scars, what you are seeing. That's it. That's the only the surgery scar you will be seeing. So it is absolutely a cosmetic surgery, or the cosmetic results will be there. The rest, all the advantage of laparoscopy, like reduced operative stay, you are just in the hospital for just 24 hours and very less pain. No stitches means no infection. If there is no infection, no recurrence of having an abdominal wall hernias, and you can go back to your work as fast as possible. Now, a very commonly asked thing, now how safe is this surgery? I will say, if you have got your surgery done by in a very high volume center and by an experienced surgeon. See, experienced surgeon is the man who does this type of surgery day in and day out. We find no major complications at all. This is my own experience also. We don't see any major, unless you have got it done in a very good center and a very experienced surgeon, no complication at all. Apart from that, there are minor, see, we are creating an artificial wall, so there are some minor alterations will be there, such as gas bloat. You will feel some bloating because now the wall is tightened up, the lower sphincter will be there, which may help to have which may cause some gas bloats. Some initial difficulty will be there to belch, because we are creating, now you are used to have a lax wall, now the valve is created. So maybe initial 2 to 3 weeks you will have a difficulty to vent your air or to belch, but that gets slowly resolved with the 2 to 3 weeks post-operatively. Now, we what I told was it's my own personal experience. I want to also share you what the world literature or the data says. It's a very busy slide. Sorry for that. This is the Sages Society data I'm telling you. I'll just read it. The satisfaction rate for surgery rates from some 82 to 97, which is a very high, and the level of evidence is very high, level 2, with long-term satisfaction. Long-term satisfaction is that more than 5 years, the maximum, the data available is up to 11 years. So up to 11 years, the satisfaction rate is up to 97%. And additionally, if you ask the patient, uh, how did they how did they felt the surgery was, and if in case in future, say after 10 years, 20 years or whatever, whenever they start getting the symptoms recurrence, if they would like to undergo surgery, 81 to 95% of the patients wants to undergo the surgery again. See, this is the satisfactory level. Patient even agrees to undergo surgery even if there is any recurrence of the symptoms on the long term. However, in a well-selected cases, I'll say fundoplication is only suggested for a well-selected, well-worked-up cases, and in such patients, the satisfaction rates is up to 99.5%. So this is absolutely the quality of life, and the satisfaction with the surgery is going to be great with the patients. Now, what is expected? I said this is one disease where I expect my patients also to be equally contributing to their cause or to their treatment. So I asked my patients, since we have created an artificial wall, we need to maintain that wall for lifelong. So there are some changes which we have to maintain, such as maintaining our healthy lifestyles. We have to maintain appropriate for our height, body weight. Diet needs to be maintained well, and you need to be on a regular follow-up with the doctors. This is the commitment I require from the patients. So if they are doing all this, and I am sure most of this patient, they will get a very satisfying results from the surgery itself. Now I'll just conclude because I'll take some questions at the end because the 30 minutes talk was there. So I'll just conclude with few closing remarks saying that it is very effective at restoring the mechanical barrier to the reflux. Means like we are creating a barrier for your reflux with significant improvements in the sphincter functions, and it can be performed safely with minimal morbidity and mortality, and also leads to high satisfaction rates with the patients and very well improved quality of life. I thank you for giving your wonderful time in this weekend. And during this last 5 months, we had a tough time also being a surgeon, because there are a lot of restrictions with doing the required surgeries. But in these 5 months also, with appropriate care and safety measures, we could do around more than 2,000 surgeries. Now we have already crossed more than 2,000 surgeries without any mortality and our hospital has completely maintained an corona free environment. Thank you. I would like to take any questions here around. Yeah. So there is one question from Dr. Shashidhar Patil: who are prone for GERD and how to differentiate in other causes of chest discomfort at the primary level? Uh, at the primary level is important for us as we primary care physicians. Please help us in these issues before sending them for a secondary tertiary level setup like your hospital gem, including a very well formed question here from Dr. Shashidhar Patil. I think he's also a physician, because I said one of the symptoms of GERD was a chest pain. So many of the time there will be a very confusing whether this chest pain is because of the reflux or it's because of chest pain. I say, see, many of the time the chest pain can mimic both the similar times. So whenever is a doubt, there is a one way of to take it as you just take up one ECG and make sure you rule out the cardiac cause. Once cardiac cause is ruled out, absolutely you can put him on some antacids or changes in the lifestyles, which should definitely help to decide upon whether this patient is responding or not. See, in any of the reflux disease, the treatment is going to be there for initial, like say 4 to 6 weeks. Then only we can say whether this patient requires further evaluation or not. So you put him on the medications for 4 to 6 weeks and then take a call whether this patient requires a further referral to a tertiary care center or the secondary or tertiary care center. Now, uh, any side effects with the surgery? This is been asked. I said the side effects of the surgery. I said in a high volume centers and from a very well experienced surgeons. I said the complications rates are very negligible or very minimal, very minimal. In spite of that, there are very commonly seen alterations in your this thing. That one is, I said, a glass bloat syndrome. You tend to have some bloating up of symptoms, and there is another entity of difficulty to vent, that is very difficulty to belch, that can, because now you have created a wall. So I won't see much or any significant. This is absolutely a safe surgery, so I don't think you should be worried on this. And there is one question from Mr. Rahman. I had been suffering from lax LES problems, Sompras, Synthaprid, 1 mg twice daily I have taken, but no improvement, sir. Nissan's fund application can make permanent solution. Had suffering severe burn. Yes, I just see, I want to tell Rahman that lax LES is nothing but what the sphincter dysfunction, that what we saw. Initially, will be put on the medicines like what you have been correctly taking, the Sompras, L and Syntapride. These are the very good medications that has been taken. Along with, I suggest you to have changes in your diet and lifestyle. Diet and changes in lifestyle should be done under medical guidance, not just by own. And if it is not improving, and if on further endoscopy we start seeing say complications of GERD, definitely you will be benefited from the fundoplications. But we need to have a basic test. I said we need to do the 24 hours pH study as well as the manometry to make sure that you will benefit from the surgery. So this surgery is not for everybody. It's only in a well-selected patients. You make sure your surgeon or your doctor understood you well. See, sir, it is only we are creating a mechanical barrier. We are not going to change your physiologically. Your body's acid secretion, everything is going to be same. We are just creating a valve. We are creating a barrier to prevent the reflex going up back. So in a very well-selected patients, this surgery will work like a miracle because surgery will definitely prevent the acid coming up and it will get rid of you taking medications for a very long. Thank you, Rahman, for the question. And let's see what other questions are there. How the pain will be there after surgery? See, the medical treatment has advanced from open surgeries, which were even this surgery when it was initially found out, it was done through an open approach where you have to open up your upper part of a stomach and some part of the stomach. I mean, the chest also need to be opened. That was a very painful surgery. Now, because with the laparoscopic approach, the surgery is done entirely with the small holes. See, the tissue handling is going to be very accurate and no collateral damages to the other tissues, like no much of opening, no closing, switching. The pain is going to be very minimal. But you have to understand the internal surgery is going to be the same only. Maybe the outside skin cuts are going to be avoided, but the internal surgery is going to be the same. So I will say there is no pain at all, but definitely there will be mild pain will be there, but it's absolutely a bearable pain. So we can definitely manage. So you should not be afraid of mm, getting an opinion for your long-term complications of GERD. Okay, I think I'm very close to my closing time. I thank you everyone for giving your valuable time during this weekend, Saturday. Hope my session was this session was absolutely for an information, not to treat anybody, just to make you aware of the treatment options available. So I hope it might add to your knowledge for seeking the medical help. Uh, I am there here around. If you want any help suggestions, feel free to type your questions in the Facebook. I will reply back on the Facebook wall. Thank you very much. Good night.